This lesson is about junctional rhythm. In a normal heart, the SA node is the primary pacemaker of the heart, producing sinus rhythm. However, if the SA node, for some reason, is unable to pace the heart, what's going to happen? Well, fortunately, your heart has redundancies in place that can pace your heart if the SA node is unable to. The AV junction can pace the heart. So the AV node, the bundle of His, in this area can pace the heart and produce a rhythm that supports life. So what's the big difference between sinus rhythm and junctional rhythm? Well, both rhythms are expected to be regular, so regular RDR intervals. However, the AV node paces slower than the SA node. So it's expected to pace between 40 to 60 beats per minute. And that makes sense because you wouldn't want the AV node to pace at the same rate as the SA node, because then they'd be competing all the time for who's going to pace the heart. So the AV node paces slower in order to provide that top-down electrical conduction. The PR interval is expected to be shorter, less than 0.12 seconds. And the QRS interval is expected to be, or the QRS width is expected to be relatively narrow. So let's look at how these two rhythms compare. So just as a refresher, the SA node is up here, and I'm going to draw some electrodes. I'll draw one that is sensing that electrical activity. So these are the electrodes that you put on the patient if you're doing an EKG or for mobile telemetry. And those electrodes are sensing that electrical impulse coming from the heart. And we're just going to say this one is, like on an EKG, we'll just say it's V4. So when the SA node initiates atrial depolarization, that electrical impulse travels across the atria, depolarizing those cells, causing that muscle tissue to contract. And it does that in a direction towards this positive electrode, which then produces a positive deflected P wave. And then that electrical impulse travels down through the AV node, down through the bundle branches, producing your QRS, and then the repolarization is your T wave, of course. So that's just a quick refresher on sinus. Now, when the AV node initiates depolarization, it does it kind of in the middle of the heart, sort of. So when that electrical impulse depolarizes the atria, it's depolarizing the atria from the bottom up. Now, is this moving towards or away from this positive electrode? It's moving away from it. And what that does is it produces a negative deflected P wave. Now, the rest of the electrical conduction system works normally. The electrical impulse travels down through the bundle of His, down through the bundle branches, producing a relatively narrow QRS. And that'll look the same as any sinus rhythm QRS. The only real difference here are the differences in the morphology of the P waves. And you can have a variety of different scenarios producing different P wave morphologies. Also, because the AV node is depolarizing the atria from the middle, and it depolarizes the top and then also the bottom almost at the same time, you end up with this short PR interval. That's where that comes from. So let's look at some different P wave morphology scenarios. And this is what really makes junctional rhythm confusing for people, because there are several different ways that junctional rhythm can present. And it really comes down to timing. What happens in the heart? When does it happen? So the first example we're going to look at is inverted P waves. We just talked about that. When the AV node paces the heart and depolarizes the atria, first produces that negatively deflected P wave, and then it depolarizes the ventricles, you get a short PR that is inverted. Now, what about hidden P waves? Well, if the AV node paces the atria at the same time as it's pacing the ventricles, then what you get is you get a P wave that's hidden inside the QRS. So you really don't have anything visible at all. There's a P wave hidden in there. It's just hidden by the QRS wave. So that's if the atria is being paced at the same time as the ventricles. You can also have retrograde P waves, and this is when the ventricles get paced slightly before the atria. And that looks like this. You've got the ventricles being paced, and then you might have a P wave slightly visible just after the QRS complex. You can also have an upright P wave that's short. And this happens when the SA node is initiating atrial depolarization, but then the AV node depolarizes as well. Like that. And what that looks like is this. You have the SA node that's starting depolarization, and then the AV node paces, which produces kind of a fusion of the two. So that's how you get a short upright P wave with a junctional rhythm, is you have this kind of a competition between the two. The SA node is initiating the atrial depolarization. However, the AV node paces prematurely, and you get kind of a mixture of the two. And this is why junctional rhythm is confusing for a lot of people, because you have all these different scenarios that can occur that can produce it. So we're going to go through some of those scenarios, and hopefully we can make this easier to understand. Okay, this is just an example strip of junctional rhythm. You can see here you've got, looks like a negatively deflected P wave that's reasonably short. Looks like it's just inside 3 small boxes, which would be maybe 0.11, 0.10, something like that. Okay, the causes of junctional escape rhythm. Why would the AV node need to pace the heart? Well, sinus bradycardia. So if the SA node is pacing too slowly, we said that the AV node paces between 40 to 60 beats per minute. So if you have some extreme sinus bradycardia where the SA node is pacing as low as, in the 30s or 40s, the AV node now all of a sudden can be competitive, and it can potentially outpace the SA node. Sinus arrest, if the SA node stops pacing altogether, then you would want the AV node to pace. And then heart block, which we'll talk about in a later video. Okay, sinus bradycardia. Here's a manifestation of how you would transition from sinus bradycardia into a junctional escape rhythm. You can see here, the R to Rs are getting progressively longer, which means your heart rate is slowing way down. And this is driven by this atrial rate here that's just getting much slower until the AV node is finally able to pace the heart. And you can see here there's no P wave visible, so it could be hidden in here. And this is just a result of the SA node pacing too slowly. Okay, sinus arrest. So the SA node is pacing. You can see here, and all of a sudden there's nothing. And then junctional rhythm ensues. Okay, here's an example of the AV node pacing prematurely. Just like we talked about in the atrial lesson, where you can have PACs that can pace from other areas that interrupt sinus rhythm. You can have impulses from the AV node that pace prematurely and interrupt sinus rhythm as well. And we call those premature junctional contractions, or PJCs. Now these PJCs, they have, just like with other junctional rhythms, they have relatively narrow QRS, and if you can see a P wave, it might be inverted. However, it's often with the fact that the PJCs are early and the P waves get muddled in the T wave, sometimes it's hard to tell whether it's a junctional beat or if it's some other atrial ectopic beat. So a lot of times they're just called PACs. But specifically, if you can see it short and inverted like that, you could call it a PJC. Okay, accelerated junctional rhythm. This is when the AV node is pacing at a rate between 60 and 100 beats per minute. Accelerated junctional rhythm, since it's pacing at the same rate of the SA node, it's usually more of an interruption in rhythm, and it's not something that you generally want to happen. You can see here you've got no P waves, narrow QRS complex, and a rate between 60 and 100 beats per minute. Okay, here's another way that accelerated junctional rhythm can pace the heart. Here you've got sinus rhythm. You can see there's P waves here, and then all of a sudden you see the PR get much shorter than it was previously. And then it looks like that P wave is just merging into the QRS complex until it just disappears. Now this is an example of accelerated junctional rhythm, and it's outpacing the SA node. So that's how you get this short upright P wave that's merging into the QRS complexes, because the AV node is now able to outpace the SA node. Junctional tachycardia, it's just faster, greater than 100 beats per minute. And this example strip down here, you see these retrograde P waves that are just after the QRS complex. And that concludes our lesson on junctional rhythm.